Why you need an X-ray? You need an X-ray for getting information, not for the heck of doing just X-ray kar liya. If you just do an X-ray just for the sake of doing it, yes, you will make money, but you will not be able to establish a diagnosis. And if you miss a diagnosis of scaphoid, you are heading for a trouble. And therefore you need an appropriate view. You need a good quality X-ray. So if you have an X-ray like this, you don't see anything. It's a useless X-ray. It doesn't tell you anything. That system of dip and mercury solution is obsolete now. You need a very good quality X-ray, and that too magnified into particular views. Otherwise you will not get the information you are seeking. Whether PA or AP. Now when you are having a PA, the ulnar styloid process is right at the flank, almost at the side, the ulnar side. This is PA view, and you need a PA view when you are seeing the scaphoid. As against an AP view, the ulnar styloid process moves more toward the radius. So you need a PA where the styloid process of the ulna is far ulnar. So coming to the scaphoid, you don't need an AP and lateral, which is a standard for most of our orthopedic practice. You need a very specific view and a specific position of the patient also. The shoulder is abducted, the elbow is flexed, the wrist is in ulnar deviation, and the closed fist. And this has to be the position when again the word is point tenderness. So what patient says, I have a fall on outstretched hand. Patient has an outstretched hand. Where is the pain? First thing, outstretched hand means you see anatomical snuff box. Is it tender? We'll come more about it. The moment anatomical snuff box is tender, think scaphoid, and keep thinking scaphoid till you have completely ruled out. Otherwise you can miss it. And therefore keep thinking till your thinking is over. So, ulnar deviation and closed fist. Now what is happening is, when the wrist is in ulnar deviation, the scaphoid is almost parallel to the cassette. When the wrist is parallel, and when the wrist is not in ulnar deviation, the scaphoid is angulated. When the scaphoid is angulated, the fracture site can superimpose and hide the fracture. And therefore you have to do an ulnar deviation so that the scaphoid lies parallel to the cassette, and you will pick up a fracture of the scaphoid. So PA of the wrist in ulnar deviation with the fist closed is one view. This is called as a scaphoid view. The next thing that you do is, patient remaining in this position, ulnar deviation, the tube is tilted by 30 degrees. Patient remains stationary, shoulder abducted, elbow flexed, wrist in ulnar deviation, but the tube is tilted by 30 degrees, and you take a second view. So tube tilted 30 degrees is second view. So it's only when the wrist is in 30 degree with an ulnar deviation you see this fracture. And if it is a neutral, you will probably miss it. And therefore ulnar deviation view is extremely important to pick up a fracture which would otherwise be missed. So in summary, point tenderness, snuff box, take a scaphoid view.